Okay, thank you to the SMS for having me. We're going to be talking about vulvodynia and other pain disorders that we need to know about. I have no disclosures. So there are many causes of pain in female sexual dysfunction. The goal of this 10-minute talk is to provide a framework for approaching pain disorders, and that is a region-based approach for female pelvic pain conditions. So as we can see, there are many pathologies that may underlie these disorders, and we'll get into them. But we approach diagnosis and management by bucketing into regions so that we can localize the problem. The key to a region-based approach is understanding this anatomy. We see in green here the pudendal nerve conveys somatic sensory information from the clitoris, the vestibule, the vulva, the perineum, and the perianal region up to the brain. The pelvic nerve conveys visceral afferent information from the clitoris, the vestibule, the urethra, the bladder, the umbilicus, the vagina, and the rectum. And many of us are familiar with the sciatic nerve that conveys somatic information from the lower back, the buttocks, the thigh, the calf, and the foot. But what's really key is that they all converge at the S2 and S3 foramina to enter the cauda equina like a cable, forming the S2 and S3 nerve root. So irritation of that nerve root, also known as sacral radiculopathy, can cause clinical symptoms involving the sensory fields, in other words, in the genital pelvic region. And this is what we call a genital pelvic dysesthesia. In this example, the pathologic trigger is in the back. It's in the cauda equina, even though the symptoms are in the genitals. So as we see here, compression of any of these sacral nerve root fibers, for example, the fifth fiber listed there is the labial nerve. That's a branch of the pudendal nerve, and that will present with vulvar pain. So let's start with region 1, which is the end organ. There are many causes of pain and dysesthesias in region 1. You can have keratin pearls or clitoral adhesions, Bartholin cysts, GSM, infections, etc. I think it's best to kind of approach these with index cases. So we'll start with MJ, who is a 24-year-old who presented with the inability to have penetration. At 12 years old, she had searing pain inserting a finger into the vagina. At 13, she could not use a tampon. At 16, she could not use a sex toy, and she could never tolerate a speculum exam. Touching her umbilicus elicits pain. Hormonal blood tests are within normal limits, and she has a past medical history of hypothyroidism, food allergies, TMJ, and seasonal allergies. And these are conditions associated with aberrant mast cell activity, and we'll circle back to why that's important. So there are many causes of vestibulodynia, lichen planus, lichen sclerosus, vaginitis of multiple causes, high-tone pelvic floor dysfunction, and then there is vestibulodynia, and that can be hormonally mediated or it can be neuroproliferative. Neuroproliferative vestibulodynia is a genetic predisposition where there is an increased density of mast cells in the tissue, specifically of the vestibule, shown here by those circular brown cells in the past staining. And those mast cells release nerve growth factor. So on the right side of the slide, we see the increased nerve density in the vestibule, and that's why these patients have such exquisite and sensitive pain. So the first step in diagnosis is to exclude the other causes of vestibulodynia, some of them shown here. We then proceed with what's called a vestibular anesthesia test. So using the vestibule like a clock face, we elicit pain scores with a Q-tip. After we have those pain scores, we then apply topical anesthetic directly to the vestibule. And if the pain gets better, we've localized this to the end organ. In other words, the problem is in the vestibule. So that was the case for MJ, so we proceeded to a vestibulectomy, and we found, of course, increased density of mast cells, increased density of nerve fibers on staining. At 6 months post-treatment, she's now able to be pain-free and have enjoyable penetration. So take-home messages for Region 1 disorders. There are many etiologies: infectious, hormonal, mechanical, etc. The etiologies trigger genital pelvic dysesthesias and pain via pathology in the somatic pudendal nerve of the clitoris, of the vulva, the visceral afferent pelvic nerve of the vestibule, and ultimately numbing the end organ, in other words, the vestibule itself, or the clitoris or the vulva with resolution of pain is diagnostic of a Region 1 genital pelvic dysesthesia. So region 2, pelvis and perineum. We have many symptoms and many pathologies for region 2 disorders. We are very familiar with urinary urgency, frequency, pain during filling, etc. We see a lot of region 2 disorders after a LEAP procedure. We see this with avid cyclists, both male and female. We see this after birth trauma. So our index patient is Miss CC, a 68-year-old who presented with severe burning located in the perineum through the vaginal area, extending to the labia and the clitoris for 1.5 years. No pain in the vagina or rectum. She'd fallen on her crotch in the past multiple times, and this was because she was an avid cyclist. So our diagnostic algorithm begins with something called neurogenital testing. We start with quantitative sensory testing, in other words, testing vibratory, heat, and cold sensation of the end organ. This should be abnormal. We then do a bulbar cavernosus reflex latency test, and the idea here is that if there is any disruption of the reflex arc, that will be delayed or abnormal. The third test is a sacral dermatome test, and this is the key here. In region 1 and region 2 disorders, there is nothing wrong in the back, nothing wrong in the cauda equina. Therefore, the sacral dermatome testing should be normal, and that will distinguish a region 1-2 disorder from anything higher up. Once we have that, we then proceed to do our anesthesia tests. So in these pictures, we're numbing the clitoris, presumably, and numbing the vestibule. CC and patients with region 2 disorders do not get relief of their symptoms. Even though the burning that she has is in the clitoris, numbing the clitoris itself does not relieve her pain. At this point, we proceed to a diagnostic pudendal nerve block. And if there is clinically significant symptom reduction, then we know that the cause is a region 2 disorder, and then we treat the pudendal neuropathy. She got serial pudendal nerve blocks as well as pelvic floor physical therapy, and a year later, after 4 blocks, she is free of pain in the perineum through the vaginal area, extending to the labia and the clitoris. She can sit and lay in bed without triggering pain, and she no longer does traditional bicycle riding. She now does stand-up elliptico bike riding, which Dr. Goldstein tells me is all the rave. Region 2 take-homes, the end organ, in other words, region 1 anesthesia test will be negative. Region 2 triggers can include pathology in the somatic pudendal nerve in the perineum. It can include pathology in the visceral pelvic nerve after rectal surgery, pelvic cancer surgery, or pelvic irradiation. And successful treatments of pudendal neuropathy have been reported to successfully treat persistent genital arousal disorder as well as genital pelvic dysesthesias like pain. So finally, region 3, the cauda equina, we see Tarloff cysts or annular tears can cause these pathologies. So AP is our patient, 44-year-old, presented with pain with intercourse, nerve sensation with sitting, traditional sciatica, persistent genital arousal disorder, and pain in the back of the vagina. She had a history of falls after being a competitive figure skater. Again, coming back to this anatomy that is key, we see that the pudendal, the pelvic, and the sciatic enter the cauda equina as a cable, as a singular nerve root. So any compression of these sacral nerve root fibers will cause these abnormal sensations, these dysesthesias, and that can be pain, that can be arousal, that can be broken glass sensation, etc. We've shown that lumbosacral annular tears can induce sacral radiculopathy and result in PGAD and GPDs. And that's, as we see in this little schema here, the annular tear causes the dura to be concave, compressing the nerve roots. And in that same study, we show the location and types of dysesthesias in the genital pelvic region. So sexual dysfunctions involving genital pelvic-based symptoms can result from pathology in a remote location. And this is what we call genital pelvic sciatica. And this is specifically from a lumbosacral annular tear in the cauda equina. And we're familiar with a number of these disorders, things like hard flaccid syndrome, sleep-related painful erections, clitoridynia, and vulvodynia. So AP had an L5-S1 annular tear. Her neurogenital tests were all abnormal. Region 1 and 2 anesthesia tests were negative. We did a test epidural injection of lidocaine, and she had relief. So therefore, she underwent endoscopic spine surgery and physical therapy, and she now no longer has pain with intercourse, nerve sensations, sciatica, or PGAD. So take-home messages. Region 1 and Region 2 anesthesia tests will be negative because the pathology is in the back. Region 3 triggers include pathology in the sacral and lumbar nerve roots in the cauda equina, and successful treatments for genital sacral radiculopathy have successfully treated PGAD and GPD, including vulvodynia. Thank you.